Well, according to the National Institute of Communicable Diseases, latest figures, South Africa has recorded another 15,501 new positive COVID-19 cases. This was in the last 24-hour cycle. The deaths recorded are the highest for the country since the 2nd of February. And this now takes the overall COVID-19 fatalities to 62,628. I think, if I'm not mistaken, the deaths recorded were 576. I'm not too sure. I'll double check that and get that number to you. 556, I think that was the amount that were recorded in this last 24-hour cycle. Gauteng accounts for most of the new infections at 9,218, followed by the Western Cape with 1,574. Active cases countrywide have, however, decreased to 183,243. Now, there have also been reports of a new COVID-19 variant detected in the country. And we've asked the NICD's acting executive director, Professor Adrian Puren, to help us clarify and unpack the latest trends and talk to us about the variants that we're struggling with at the moment. Prof, thanks very much for joining us. It's a pleasure, as always, to have you on the program.
Very good morning to you and good morning to your viewers. Thank you for the opportunity.
Let's start up very first now. There's the talk of the new variant, the Lambda variant, which of course is one that was first discovered in Peru. From a little bit of reading on it and research, this particular variant is said to have an extremely high mortality rate. First up, have we or have we not detected this in South Africa as yet?
So categorically, we've not detected this particular variant. As you know, in South Africa, we do have a network of laboratories, both in the public and private sectors, and that are constantly monitoring for variants in circulation and obviously focusing on variants of interest or of concern. And at this time, we have not detected this particular variant. I know it has been in circulation in about 30-odd countries. That included, I think, reports from Zimbabwe, Egypt. But at this time, no, we don't have this particular variant.
So
I know it is a variant of concern or of interest because of its distribution and also because of the nature of some of the mutations. But at this time, we have very little information around this particular variant.
So, I mean, you say as close as Zimbabwe, our neighboring country, and we see many citizens in and out of South Africa all the time. So chances are, without speculating, that this case, these variants may be detected, and they spread very fast.
They certainly are, fairly, because of the mobility that we see in terms of modern-day travel. So certainly trying to control borders becomes very difficult. So I think that we may well see it. It may well not. It may well not arrive in this country. For example, we've not seen the Brazilian variant, the variant from Brazil, rather. Let's put that correctly, and that's probably because of the nature of the travel. But it's possible that we may well detect it in time, but it may not be the dominant variant, as we have seen with the Delta variant, which has really become the dominant variant worldwide.
Yeah. So, I mean, the Delta variant, I remember having conversations all the time asking different specialists, professors such as yourselves and those from the NICD as well, talking to the Delta variant from the health department as well, and kept insisting that no, the Delta variant was not a cause for concern in South Africa. We'd only found 4 cases and that was about it. And then suddenly, 2 days before we went into a lockdown, this was now the dominant strain and spreading so fast. I think there tends to sometimes be a bit of a trust deficit with the public and what we're being told. Is that fair to say, when perhaps there is the information out there, but maybe it's not getting to us fast enough?
Yeah, so I must say, from my perspective, I did try and emphasize, in fact, that was the variant of concern, I think, in the sense that when you saw what happened in India, and then in the UK and in the United States, I think, and especially when there are pronouncements, especially from various organizations that do label it as variants of concern, I think then the public needs to take that very seriously. I think when you do detect the variants, obviously, the point is, yes, it is of concern, but can we manage and control that particular variant in terms of doing the necessary testing, tracking and tracing and isolation? Those are the key components, in fact, to try and control and limit the spread of this particular variant, of the variants of concern. So obviously it was detected fairly early on, and that obviously raised alarm bells for some of us. And of course, there's always that lag in terms of data, because it takes almost 2 to 4 weeks, in fact, sometimes, to get more data around what is the nature of the variants in circulation. But I think the variants certainly outpaced whatever we had tried to do, and Delta is just a good example of a variant that, because of its high transmissibility, rapidly changed the setting of what is in circulation in South Africa in a few weeks, in fact, yes.
Yeah.
Absolutely. So you're quite right. It's important for us to keep track, and once we detect, we should really be rigorously trying to control. But I think it sometimes becomes very difficult in settings where you have large numbers. It just becomes difficult.
There have been a couple of articles coming out about, I'm not saying the Delta variant, because that's still, the efficacy of the vaccine still seem to be working on that, but there's a little bit of speculation and worry that this new Lambda variant could be dodging some of the vaccines, and that is a bit of a worry. What have you seen from research?
So again, very limited research, but at least one of the so-called preprints, so it has gone through peer review yet, seems to argue that, in fact, it may not be the case, although it is, as I said, a variant of interest because of the nature of the mutations around possibly some immune escape. At least one preprint, I think, does demonstrate that may not be the case, at least for the mRNA vaccine. So that may well be useful, but it's important to keep track of the publications and work that's being done around the different settings to see whether that is confirmed. Yeah.
All right, let's get into where we are at the moment with South Africa. I mean, we saw record cases being reported over the weekend, in excess of 26,000 in a 24-hour reporting period. We're seeing the second highest daily death toll reported in a 24-hour period, and this was reported last night. Give us your sort of views. Where are we at right now? I mean, are we still in a very, very worrisome position as a country?
Absolutely, and in particular in Gauteng province, as you can see, the trajectory is still upward. The positivity rates still remain substantially high, and that means that even though it may be 2 out of 3 cases that may be positive, that means it could well be a larger number of individuals that are being currently infected that may not be presenting for clinical care or hospital care. So yes, it is still of importance in South Africa, especially Gauteng. Of course, Western Cape, certainly you're starting to see the upward trajectory there. And KwaZulu-Natal as well, you're starting to see Mpumalanga and Limpopo. Again, Mpumalanga, I think Limpopo had a positivity rate of 40%, which is remarkable. So again, the levels of testing that needs to be done there to really get a good, clear picture is really, really critical. Yeah. So as you know, the various provinces have their resurgence plans. So I'm hoping that these types of data, the modeling data, really assists them to really understand what it is that they require in terms of bed capacity, oxygen supplies and logistics in order for them to really manage this. I think the initial models did not take into account the fact that there would be the Delta variant. So obviously the Delta variant now changes that particular scenario. So although we had evidence from the models, or at least from the scenarios, that in fact this particular resurgence should not be to the same extent as the second, the Delta variant certainly changes that picture. So it's really critical for provinces to really take this very seriously and make sure that their resurgence plans will manage the larger potential large outbreaks. But it also comes back to the fact that we are at a level 4, a readjusted level 4. We'll see what effect that will have. I'm hoping to certainly contribute to flattening the curve. But again, it comes down to that leadership level. It comes down to the personal level to really try and ensure that we reinforce the non-pharmaceutical interventions, because that's essentially what we have currently. Our vaccine rollout is not going to be to the extent that it's going to have any great dent in terms of so-called herd immunity. I'm hoping it will have an effect in terms of the healthcare workers, at least providing some level of protection there. but we're not going to reach herd immunity through this particular phase.
Yeah, certainly. I mean, we're trying, we're seeing record numbers in vaccinations happening daily. I mean, I think we were over 150,000 yesterday, which is very, very promising, but it's not enough. I mean, we know we've got a very, very long way to go. Let's talk about these regulations that are in place right now. And if I'm not mistaken, they come to, well, I mean, the president said this will be for the next 14 days. So I think that's coming up this weekend, whether it be Saturday or Monday. I'm not too sure. I haven't calculated correctly.
Sunday, I think it is.
Is it on Sunday? Thank you. That's why you're a professor.
I think it is.
Yeah.
No.
So it's coming up on Sunday. From what you're seeing, obviously the data we get it is delayed. It's not immediate, but do we need a longer lockdown to get this flattened?
Well, I think it depends on the next few days what's going to happen in Gauteng. If we do see at least a change, perhaps, then one could possibly consider either saying that, yes, that trajectory is promising, or that, in fact, we may have to extend it. These lockdowns sometimes would have to be extended because the effects, and as you can see, for example, the mortality only lags. So you'll only see the increases in mortality fairly later on. So you have to deal with what you have now. And that means you may have to decide whether or not that trajectory, is it coming down? If it's not coming down sufficiently, then in fact you may have to extend the lockdown in order to really try and reduce further transmissions. Yes.
Yeah. I mean, when we talk about the fact that the Delta variant is spreading so fast, how bad is the spread? I mean, when we look, say, somebody in a room is infected with COVID, how fast does this thing spread? Give us an understanding, an idea of how infectious this actually is.
So when we started off with this particular virus, we had what is called the reproductive number. And I think it was about 2 to 3-fold, in other words, was the so-called R, or effective R. The recent calculation shows that it could reach between 7 or 8. So that's 2 to 3 times higher than what we're currently observing for the current beta variant that was in circulation in South Africa. And it's thought to be about 40 to 60% more transmissible than the so-called alpha variant. So it's really highly transmissible.
Wow,
yes.
Yeah. When we look at the symptoms, and that's something that a lot of people have been speaking to, we were always told about the fever and the cough and the loss of smell and taste with the variants that we've been through, the alpha and the beta. However, there seems to be a little shift in the different kinds of symptoms that one is actually feeling with this Delta variant. And please correct me if I'm wrong, but I mean, some people may have a cold and they're walking around thinking it's just a cold. Meantime, that in itself is COVID and you don't even know you've got it. Has there been a slight shift in the kind of symptoms we're seeing in this Delta variant?
Yeah, I've seen some reports around the fact that you may have, as you called, the runny nose, the headache, and the fever. But again, my sense would be that the constellation of symptoms are probably the same as it ever was. So I think if there's a high index of suspicion and there are opportunities to test, then I certainly would. But if there are opportunities not to test, then I would simply go into isolation. That would be the best, as long as you're well. Sufficiently well to isolate it at home. But if you're really feeling, again, it's about the shortness of breath, the lack of oxygen, those sorts of difficulties that you may have, regardless of a runny nose. I think that when you're ill, then certainly seek healthcare assistance.
Yeah. We keep talking to testing, and testing is probably the best way to understand where a country is really at. And, funnily enough, I put out a question on social media this morning talking to how much people have actually paid for testing. And I do know that some medical aids obviously do pay for it, but people that are not on a medical aid and cannot get to a public facility have to pay for these tests themselves. And we're talking $8.50 for a test, if not more. Some people are talking how many they're paying for one family, and they just can't afford to test anymore. Is this an issue from the NICD's point of view, that perhaps not enough people are testing because they simply cannot afford to test?
That may well be a contributory factor, but I do know that, at least in the public sector, there should not be any marked payments unless you're on a medical aid, I think it is. But I think in the public sector, at least, those tests should be available. In fact, they've also introduced the antigen testing. And in fact, the antigen testing should actually, if you're on a medical aid, should actually even be less expensive. But even for an individual who is not unable to afford it, that test should be available, especially if you're presenting in a state where you require hospitalization, for example. So the antigen testing has certainly changed the nature in which we are providing diagnostics. In fact, when you look at some of the numbers that are coming through, very often the antigen test numbers are far larger than sometimes or matching the PCR results. So I think testing is available, it should be available. I think people should not be, if you like, not allowed to be tested if they cannot afford it. I think it's really critical that we get a good understanding, because again, if you look at Limpopo, for example, where you have 40% positivity, I mean, that's remarkable. And we've seen higher rates in Gauteng. That means we're not testing as much as we should be, according to World Health Organization guidelines or recommendations, because then we don't really have a good sense of what's actually happening around the country in terms of managing our particular cases.
Yeah.
And therefore, we're seeing these large numbers of people in hospital. But again, as you quite rightly say, there are probably people who cannot afford to test or are unwell and not presenting to hospitals to seek attention.
And that, I think, is a reality, Prof. I mean, there are many, smaller clinics and public places where you can go get tested, but they have got so few. I just talk about the one in my area. They have 20 on a day if they're lucky, and by 8 in the morning, they're gone. If you get there first, you're lucky. If not, then you've got to find another way to get a test, and that means paying, which people can't do. But that is something I think we need to look at quite carefully. We're running out of time, but there's one issue I would like to just get your views on finally, and that, of course, is ivermectin. We've seen studies coming out, and probably some of the best studies now being conducted into the use of ivermectin to treat COVID. I know it's a big sticking point here still in South Africa, but the findings basically saying that it doesn't necessarily help, and it may in fact increase your chances for being put on a ventilator. Would you like to talk to these findings?
Yeah, so again, I have to be honest with you, I am not too familiar with those particular studies. I can't really comment on that. But again, I think if these are well-conducted clinical studies, and again, we really look at randomized controlled studies to really get answers. Sometimes one can look at observational studies, but if it's sound scientific evidence that this does not provide sound clinical outcomes, then my sense would be that we should try and avoid it. I know that we're all desperately trying to seek some solution or some medication that will help, but if the science says that it's not the case, then I would really recommend that the public steer clear of these particular types of medications.
All right, Prof, thanks very much. We really appreciate your time. Thanks for being with us here on the program. That, of course, is Professor Adrian Puren, and he's from the NICD. He's the National Institute of Communicable Diseases Acting Executive Director, helping us clarify and unpack the latest trends for COVID-19. That study that I was talking to about COVID-19 and also the use of ivermectin, and this is something that was conducted in Argentina, and it was published in the BMC Infectious Diseases. That happened on the 2nd of July, and I know it's been quoted quite a lot. So there we go. That's pretty much where we leave it for you this morning. Sakina.
Indeed, Leanne, we have to leave it there for today.